It has probably happened to you before. You walk into the kitchen, you hear the hum of the kettle, and in that moment, everything just stops. You know you came in for something, but it slips through your mind and you forget why you're even there. If these moments are starting to feel familiar, for sure you are not alone. And just like that, time slips away and you still can't remember what you came for. If that has happened to you lately, more than once, I want you to stay with me, because what most people fear is the start of something terrible is often something else entirely. I am Dr. Evelyn Harper. I have spent most of my career sitting across from patients who came in convinced they were losing their minds. A good number of them were not. Let me tell you about a woman I will call Eleanor, 68 years old, crossword every morning. She remembered every birthday in her family without checking a calendar. Her daughter used to call her the family encyclopedia. About 18 months after her doctor added a single new prescription, that daughter called me in tears. Eleanor could not remember what she had eaten for breakfast. She got lost driving home from the same store she had visited every week for 20 years. Her neurologist suspected early Alzheimer's. It was not Alzheimer's. It was her medicine cabinet. We sat down with her primary doctor. We mapped every pill she was taking. We made some careful changes. Within 4 months, she was doing the crossword again. This is not some kind of miracle. This is preventable medicine. Today, I want to walk you through 9 medications, pills that may be quietly stealing memory from people you love right now. Ranked from the most overlooked to the one almost no doctor warns you about. Stay with me to number 1. Number 1 is not a single pill at all. It is a hidden pattern affecting millions of seniors, and almost nobody is saying it out loud. Before we go any further, I am not asking you to stop a single medication after watching this video. Please do not. Your physician knows your full history. What I am asking is that you read your bottles, ask informed questions, and bring this conversation into their office. That is your right as a patient. How many of you have a small bottle of it in the nightstand right now? Cheap. Over the counter. Number 9. Diphenhydramine. The pink pill in the bottle that says Benadryl. The label says sleep aid. What could be more harmless? Here is what that little pill is doing inside a brain past 60. Diphenhydramine belongs to a class called Anticholinergics. Remember that word. It will keep coming up. These drugs block acetylcholine, the brain's main messenger for forming memories and holding focus. A younger brain has plenty of it to spare. A brain over 60 does not. Block more of it every night. The impact adds up. A study in the Journal of the American Geriatric Society looked at older adults using diphenhydramine regularly. They faced a substantially elevated risk of cognitive decline, with measurable shrinkage in memory regions seen on brain imaging. The sneaky part. It hides in dozens of products you do not think of as antihistamines. Anything labeled PM, nighttime relief, or sleep formula almost certainly contains it. For allergies, ask your doctor about second-generation antihistamines like loratadine or cetirizine. They do not cross the blood-brain barrier the same way. For sleep, we will get to safer options later. Number 8. Proton pump inhibitors. Raise your hand if your doctor put you on an acid reflux pill years ago, and nobody has revisited it since. This is one of the most overprescribed categories in modern medicine. Most of these drugs were designed for 8 to 12 weeks of use. Many people are on them for a decade. PPIs cut stomach acid. The catch is that stomach acid does something we need. It pulls vitamin B12 out of your food. B12 is not optional for the brain. A deficiency mirrors early Alzheimer's so closely, the two are sometimes confused even by experienced doctors. A 2016 study in JAMA Neurology followed more than 73,000 adults aged 75 and older. Long-term PPI users had a 44% higher risk of dementia compared to non-users. Research suggests PPIs may accelerate the buildup of amyloid beta plaques. the same protein deposits seen in Alzheimer's brains. Talk to your doctor about a slow taper using H2 blockers like famotidine as a bridge. Smaller meals, skipping late dinners, raising the head of your bed a few inches. These things ease reflux more than people expect. If you must stay on a PPI long-term, get your B12 and magnesium checked twice a year. If this is helping you so far, drop the number 8 in the comments. It tells me you are still with me. Number 7. Bladder control medications. This one frustrates me, not because the medication does not work, because of how little patients are told about it. Overactive bladder is a real, exhausting issue. When a doctor hands you a prescription for Oxybutynin and says it will help, of course you take it. Here is what almost nobody explains. Oxybutynin is one of the strongest anticholinergics still used in everyday clinical practice. It does not just calm the bladder, it crosses straight into the brain. And it goes after the same acetylcholine systems your memory depends on. Studies have shown the hippocampus, your brain's memory center, can shrink in long-term users. A measurable physical change, not just foggy thinking. A 2019 review in the British Medical Journal looked at seniors on strong anticholinergics like Oxybutynin used for over a year. They had a 49% higher risk of a dementia diagnosis. Nearly 1 in 2. Here is the part that is not good. The early symptoms get blamed on age. Forgetting appointments, misplacing keys, losing words mid-sentence. The medication never gets questioned. The good news: newer bladder drugs like mirabegron work through a completely different mechanism with far less cognitive impact. If you are on Oxybutynin and you have noticed mental changes, please raise it with your urologist by name. Number 6. Benzodiazepines. I want to slow down here, because people have strong feelings about this category, and they should. Benzodiazepines have helped millions through severe anxiety, panic, and unbearable insomnia. For some, they felt like a lifeline. I am not dismissing that. What I am is talking is that you hear the science. These drugs amplify GABA, the brain's natural calm-down signal. Excellent in the short term. The trouble starts when that signal stays cranked up for months or years. A 2022 study tracked more than 8,000 seniors over 6 years. Those who used benzodiazepines for more than 3 months had a 51% higher risk of Alzheimer's disease. The risk was highest with long-acting versions like diazepam, which build up in fatty tissue, including brain tissue, over time. When GABA is chronically over-amplified, the brain dials down its own activity. Neuroplasticity, the ability to form new connections, starts to fade. Memory encoding slows. Emotional regulation gets shaky. And the trap. When you try to stop, withdrawal can be worse than the original anxiety, which makes the drug feel necessary, even as it is doing damage. Important: never stop a benzodiazepine cold. That can be medically dangerous. A supervised taper over weeks or months is the safe path. Alternatives your doctor may discuss include buspirone for anxiety, cognitive behavioral therapy for insomnia, and in some cases, low-dose melatonin or magnesium glycinate. Number 5. Statins. Careful here, statins genuinely save lives. Cardiovascular disease is still the #1 killer of people past 60. For many patients, a statin is appropriate and important. But here is what your cardiologist may not have mentioned. Your brain is nearly 60% fat by composition. Cholesterol is not the villain it has been made out to be inside the brain. It is structural. It builds the myelin sheath, the insulation around nerve fibers that let signals travel cleanly. When you push systemic cholesterol too low with a high-dose statin, you risk crossing a threshold where the brain runs short of what it needs. The FDA actually updated statin labeling in 2012. They added warnings about memory loss and confusion. a rare admission issued after thousands of patient reports. A 2023 analysis in Frontiers in Aging Neuroscience looked at seniors over 70 on high-dose statins. Used for more than 3 years, they showed a measurable rise in mild cognitive impairment compared to non-users. Nuance matters here. Not every statin carries the same risk. Lipophilic statins like simvastatin and atorvastatin cross into the brain more readily. Hydrophilic ones like pravastatin and rosuvastatin show much less cognitive impact. In head-to-head studies, if you are on a statin and dealing with brain fog, ask your doctor whether a hydrophilic version might give you the heart protection with less of a cognitive cost. Also, have your CoQ10 levels checked. Statins deplete it. The brain depends on it for cellular energy. If this has been useful, send it to a friend or family member on a statin. A simple share helps the next person find it. Number 4, Amitriptyline. This one surprises people because it gets prescribed for things that have nothing to do with psychiatry. Nerve pain, migraine prevention, fibromyalgia, even insomnia. It is an old tricyclic antidepressant repurposed across many conditions. Here is what makes amitriptyline uniquely risky for an aging brain. It is one of the most potently anticholinergic medications still in wide use. Its grip on muscarinic receptors is unusually strong, stronger than many drugs developed specifically as bladder or allergy treatments. A 2015 study in JAMA Internal Medicine followed over 3,400 adults aged 65 and older for a decade. High cumulative anticholinergic exposure was tied to a 54% higher risk of dementia, with amitriptyline near the top of the list. And it was not all about big doses. Even low, steady amounts over years built up real burden. The most troubling part is how invisible it is. No dramatic warning sign, just a slow erosion. Word-finding trouble, difficulty holding complex thoughts, all chalked up to aging. For years before anyone looks at the medication. For nerve pain, duloxetine or gabapentin carry far less anticholinergic burden. For sleep, low-dose doxepin in small amounts has a much friendlier receptor profile. For mood, modern SSRIs like sertraline are much safer for aging brains. Number 3, antipsychotics. I want your full attention here, because what I am about to say happens every day. In nursing homes, memory care units, and hospitals across this country. And most families never find out. Antipsychotics were developed for serious psychiatric conditions, schizophrenia, bipolar disorder with psychosis. They are powerful brain-altering drugs with a heavy side effect profile. But today, they are routinely prescribed off-label to elderly patients. Patients who are simply restless, confused, or hard to manage. Not because they have psychosis, because they are inconvenient. I will say that again. There are seniors in long-term care right now being sedated with antipsychotics. Not for their benefit, for the convenience of short-staffed environments. The FDA issued a black box warning about this practice over a decade ago, citing increased risk of death in elderly patients with dementia-related behaviors. The prescriptions continue anyway. The neurological cost. Antipsychotics work by suppressing dopamine, the brain chemical tied to motivation, movement, and executive function. Suppress dopamine in an aging brain long enough, and you get flattened emotion, slowed thinking, and accelerated decline. A 2022 study in the Lancet Healthy Longevity tracked more than 25,000 older adults. Seniors given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within 12 months. Even those without a prior dementia diagnosis. If you have a loved one in a care facility, or if you yourself are being prescribed quetiapine or risperidone for reasons other than documented psychosis. Ask direct questions. Ask why. Ask what the plan is to stop. Ask what non-drug behavioral approaches have been tried. You are entitled to those answers. Number 2, Paroxetine. This one does not get the attention it deserves. Paroxetine, sold as Paxil, is classified as an SSRI, same family as Prozac, Zoloft, and Lexapro. When most people hear SSRI, they think safer, modern antidepressant. That is true for most of them. Paroxetine is the exception. Unlike its siblings, paroxetine has significant anticholinergic activity. That single quirk pulls it out of the modern category and puts it closer to the older tricyclic antidepressants. A 2021 review in Frontiers in Psychiatry looked at elderly patients on paroxetine. They showed measurable declines in short-term memory and verbal recall within the first year of treatment, declines not seen in patients on other SSRIs at comparable doses. The American Geriatric Society has placed paroxetine on its Beers criteria, an official list of medications considered potentially inappropriate for older adults, specifically because of this cognitive concern. Paroxetine is often prescribed to older adults for anxiety and depression, the very population it puts most at risk. The fix is simple in concept. If you are on Paxil and you are over 60, ask your physician whether sertraline, escitalopram, or another SSRI might give you the same benefit. Without the anticholinergic burden, most patients transition smoothly with a careful taper. Number 1. Anticholinergic polypharmacy. I told you at the start this would not be a single pill. Here is why this matters more than anything else on the list. Every medication we just covered, taken alone, may produce only mild cognitive effects in some people. A little more brain fog, a little more forgetfulness, easy to dismiss, easy to blame on age, but people do not take one medication. The average American over 65 takes 4 or more prescriptions a day. Many take 6, 8, 10, or more. A combination of prescriptions, over-the-counter products, and supplements, often coming from several different doctors who do not see each other's lists. When a few of those carry anticholinergic activity, they do not just add up. Research suggests they multiply each other's effect. A 2022 analysis in Age and Aging tracked more than 280,000 older adults. Those with the highest anticholinergic burden had a 120% increased risk of dementia over a 10-year span, double the normal risk. From pills most of them had never been warned about. Picture what this looks like in real life. A 70-year-old woman, let us call her Ruth. She takes a Benadryl PM every night to sleep. She takes Oxybutynin for her bladder. She was recently put on Amitriptyline for nerve pain in her feet. And every morning she takes an over-the-counter heartburn pill. 3 of those 4 are anticholinergic. Each one, according to the doctor who prescribed it, is appropriate. Together, her burden score may sit in a range tied to significant dementia risk. And nobody, not one doctor, not one pharmacist, has done the math on her behalf. This is your neighbor, your mother, your spouse. The medical term is anticholinergic polypharmacy, and it may be the single most underreported driver of dementia-like symptoms in older Americans today. Now hear this part clearly. Drug-induced cognitive decline is often reversible. I have seen it personally. When the medication burden is identified and reduced under proper supervision, many patients experience a striking return of mental clarity. Memory comes back. Personality re-emerges. The fog lifts. Your brain is not a passive organ. It is adaptive, resilient, capable of healing when given the right conditions. Here is your action plan. 5 concrete steps starting this week. 1. Write down everything you take. Prescriptions, over-the-counter products, supplements, sleep aids, the occasional PM pain reliever, the allergy pill you have been on for years, all of it. 2. Look up each item on the anticholinergic cognitive burden scale. A short search will bring it up. 3. Schedule a medication review with your primary doctor. Use that exact phrase. I would like a medication review to assess my anticholinergic burden. A good physician will not bristle at it. They will appreciate the advocacy. Loop them in before you change anything. 4. Ask specifically about deprescribing. The intentional, supervised process of tapering off medications that are no longer necessary. 5. If your doctor is dismissive, get a second opinion. You are not being difficult. You are being responsible about your own brain. A geriatric pharmacist, yes, that specialty exists, can also perform a full medication review. Before you go, I want to hear from you. Which of these 9 medications are you or someone you love currently taking? Have you noticed brain fog, memory lapses, or personality changes that nobody connected to a pill? Has a doctor ever brushed off your concerns about cognitive side effects? Tell me in the comments. I read them. This community reads them. If this video helped you today, please share it. Send it to someone you love. The person who needs to hear this most is probably not going to search for it on their own. You might be the reason they find it. I am Dr. Evelyn Harper. Thank you for spending this time with me. Your brain is worth protecting. And now you have the tools to start. Stay sharp, stay informed. I will see you in the next one.